Hello, my name is Enos and welcome back to my channel. This is Work and Wonder, the home of mental health nursing OSCE. So if you're a mental health nurse who is preparing for his or her OSCE exams, then I can guarantee you that this is the only channel that talks about the mental health nursing OSCE. Welcome to this channel. If it's your first time, please make sure to subscribe to the channel, and if you are also a returning subscriber, thank you for coming back to take a look at the videos that I have been posting. So today the video is going to be very simple and it's going to center around the mistakes that you should try and avoid in the various stations, from APIE to the professional values and evidence base as well. So last year I had a lot of people contacting me, especially those people that had watched the video and then for one or two reasons when they went to take their exams it didn't go so well. Some of them shared their reports with me, and I've kind of had a lot of these reports, compiled them, and what I've done is that I've gone through them and I've tried to look at the various mistakes that cut across that a lot of people have been making with respect to each of the stations. So for today's video, we'll be looking at the mistakes in the APIE station that people did made, and then as a result it failed them. Some of them were things that they were supposed to do that they didn't do. Some of them too were things that they did that they were not supposed to do. So today we'll look at the ones in APIE, which is the assessment, the planning, implementation, and then evaluation. And then in another video we'll look at probably in the scale station the mistakes that they did, and then the last video we'll look at the professional values and then evidence base. So without wasting much time, let's just go straight into the APIE. We'll start off with the assessment station. So we all know that assessment station is a 20 minutes station. You are supposed to use 20 minutes to finish this particular station. It was just about 2 or 3 people that were not able to finish within the time, and we all know that if you are not able to finish within the stipulated time, then it is an automatic fail. It's non-negotiable. So people were not able to finish it before the 20 minutes. I always say that 20 minutes is more than enough to finish your assessment. So try and always practice using about maybe 15 minutes or 16 minutes or 18 minutes, so that in the main exams you are always able to finish before the time. So that was the number one thing that failed people. I'm not able to finish before time. The number 2 is hand rub according to the WHO guidelines. This is a very simple thing that everybody is supposed to know how to do, but sometimes out of anxieties, people do forget that they are supposed to do a hand rub according to WHO guidelines when they are starting the station, and once you forget to do it, they can also fail you for that. Then the number 3 thing is failing to recognize a setting. We all know that it could either be a community setting or it could be a hospital-based setting, and if you know the setting in which you are doing your assessment, it will really help you. Get into the end, you'll be able to know the type of recommendations that you are going to put in. But people fail to recognize their setting, and at the end it fails them because they give the wrong recommendations for that particular patient that they are assessing. Then the number 4 thing is sitting position. We all know that when you go in to sit with your patient, you are supposed to use the solar, which is you maintain a reasonable distance between you and the patient. You make sure that your body composure is relaxed. You sit upright. You do not cross your legs. This is a sitting position in which you are supposed to assume to assess your patient. But some people go in and then either they sit too close to the patient. There was one candidate that failed because she sat so close to the patient, and they stated that the candidate was invading the patient's personal space, and it made the patient very uncomfortable. I can understand that sometimes you can get a patient whose accent is really hard to understand, so you might be tempted to move closer to the patient in order to really get what the patient is saying. Don't be tempted to do that, because if you do that, it will be considered as you invading the patient's personal space, and that can also fail you. Then we also look at taking the assessment as an interview and not exploring. This is number 1 thing that failed a lot of people. This is an assessment. It's not an interview that you are doing. There's a difference between an assessment and then an interview. An interview is you ask the patient or you ask the person a question, the person answers, and then you move on. But in assessment, that is not what you do. You ask the person the question, and if the person gives you an answer, you will need to explore further to know why the patient gave you such an answer. So there's a clear difference between an interview and then an assessment. That's one thing that you should know. Some people, they ask, are you having sleeping difficulties? The patient says yes, and then they move on. As to how long the patient has been experiencing it, what are the factors that are affecting it, they don't even go further to ask. And if you don't do that, you are not really exploring the answers that the patient is giving you. And it's only when you explore that you'll be able to know where the problem is actually stemming from, and if there are you are to give recommendations to it, you'll be able to appropriately give interventions that is going to suit that particular problem that the patient has mentioned to you. So please don't take the assessment as an interview. Do it as an assessment and try to explore the answers that the patient is going to give you. Try to probe further. If the patient is stating that he or she has thought of self-harm, don't just move on like that. Some people, the patient says, I'm having thought of self-harm, and then they move on to ask another question which is not even in relation to the thought of self-harm. If you have a patient that is having thought of self-harm, that is a worry. You would have to explore to know how often these thoughts come, whether they have any plans in place, and how are they going to do it. In regards to when you ask these relevant questions, you'll be able to know how to help the patient in such situations. And then not identifying the current risks. Remember that these patients they would be experiencing some risks, but then they themselves will not know that these are my risk. So if you as the candidate is doing the assessment, you would have to identify these risks, and then you let the patient know these risks. And once you let them know, around that, you'll be able to know whether they actually have insight into these risks or they do not even have insight into that, and that will go a long way for you to be able to determine whether the patient has capacity or not. So it's very, very important that these risks, you are able to identify the risks, you let the patient know their risks, and then with that, you'll be able to determine whether the patient has capacity around these risks or even have insight into these risks or not. Very, very, very important. And then the next one is people are not identifying the interventions for the patient. So you do the assessment, you know the patient problem, you know the patient risks. What will be your intervention for these risks? People just don't identify any interventions. They just move on like that. So if you've been able to assess to come out with the risks and then the problem, you should also be able to identify or come up with some interventions, and you have to let this patient know his or her interventions. Then the next thing is giving the wrong intervention for the risks that you have identified. So people might be able to identify that the patient is at risk of self-harm, the patient is at high risk of self-harm, the patient is thinking about harming themselves, they have a plan in place, and then this candidate will still leave. The intervention will be that I'm leaving you in the community, and then I'll go, and then if possible I make arrangement for admission. If this is your intervention, that is a wrong intervention for this particular risk or problem that you have identified, because by the time you come back to say that you want to admit this patient, the patient would have self-harm already. So make sure that the risks that you identify, you are able to give appropriate intervention. If you do not give appropriate intervention, then of course you can be failed, and then they will tell you that you did not give appropriate intervention for the risk that you identified. And then the last thing is not closing the assessment appropriately. Some people just end the assessment just like that. You can't just end the assessment like that. You would need to end it appropriately. So when you are getting to the latter end, you can recap whatever you have done with the patient, and then whatever interventions that you have identified, if the patient was consenting to that, you can also retrace that back to the patient and let the patient know the interventions that the two of you have agreed that you are going to that you are going to institute for that particular patient. And then you can, mostly at the end part of it, you can ask the patient whether they have any questions for you or not. If they don't have any questions, you can thank them, and then you end the assessment appropriately. This is how you end your assessment appropriately. So don't just, after you've identified the reason, just say, and I'll end my assessment here. If you end it that way, that is not you ending the assessment appropriately. So these are, in a nutshell, some of the mistakes or some of the things that people did in the assessment that failed them, or these are the things they failed to do that failed them in the assessment station of the mental health nursing OSCE. So please take note of these things, so that if there are things that you are not supposed to do, don't do them. And if there are things that you are supposed to do, you make sure that you do them. Now let's move on to the planning station. With the planning station, the very first thing that people fail to do is identifying problems. You know that in your assessment, you are supposed to identify problems from there, and then when you come to the planning, you use 14 minutes, and out of these problems that you have identified, you use 2 of them to draw a care plan or to write a care plan for this particular patient. So people just do the assessment, they are not taking note of the problems that pops up from this assessment, and then when they come to the planning station, they are not able to write out these problems, or which is the second point, they write entirely different problems aside the ones that they identified in the assessment. Take note that when you are doing your assessment, the assessor is following, and your assessor knows the problems that have come out of that particular assessment that you did. So don't think that you can be too smart to use problems that you have already. Some people have prefabricated problems in their head that they are going to use regardless of whatever assessment they did. The problems must come from the assessment. So if you use entirely different problems from the assessment, then of course you also be failed for the planning station. Then not prioritizing your problem. So in the assessment, in the planning, whatever problems that you identify, you have to make sure that you prioritize them and you use the very top ones to draw the care plan. For example, if I have a patient who has thought of self-harm, and then a patient who is having nutritional problem, I would deal with the thought of self-harm before I even think about the nutritional problem. Because if I'm so much focused on nutrition, the patient would self-harm and die, and then what happens to the nutrition is gone. So you have to prioritize them to know that this is the first thing that you need to tackle before you move on to this second thing. And you must also know that some problems that when you solve them, it will go a long way to solve other problems. Something like a problem of low mood. If you have low mood and in your problems you realize that the nutritional problem or the sleep problem that this particular patient is experiencing is related to the low mood, then what it means is that if you are able to solve the problem of low mood, it will go a long way to solve the problem of nutrition and then the problem of sleep. So in that case, you know that the low mood is much more of a problem to tackle than either the sleep or the nutrition. So you have to make sure that you prioritize your problem. Then wrong evaluation and nursing intervention. Some people are also able to identify the right problem, the problems all right, but then when they are writing out their interventions for these problems, they use the wrong interventions. For example, thought of self-harm. The patient is actively having thought of self-harm, and then one of your nursing interventions is that the patient should be nursed on general observation. This is a patient who has thought of self-harm. General observation is not an appropriate type of observation for this type of patient. The appropriate one will be eyesight nursing observation, so that you have a nursing staff with this particular patient at all times. If the patient wants to self-harm, they'll be able to intervene in that regard. So try and always make sure that your nursing interventions that you have identified for the specific problem that you identified, they kind of match. And then these nursing interventions are appropriate for the nursing problems that you have identified, as well as your re-evaluation. When you are also re-evaluating, you have to make sure that the time frame is right. For example, if the patient is having problems of sleep, you can't say that to be re-evaluated on every shift. If you say that to be re-evaluated on every shift, means that when I come on shift, I have to re-evaluate. It has to be usually the next day because if you have a patient who have a problem of sleep, a patient will have to at least sleep throughout the night for you to be able to identify this patient is actually having a good sleep pattern or not. But if you say today the patient should sleep, and then you identify, you'll be able to look at whether the patient is having a good sleep pattern or it is not just possible. So you have to make sure that all the problems that you have identified, you have the correct or the appropriate interventions for them. Then the last thing will be that you not signing, dating, and then putting your initials. So when we look at the planning answer sheet that will be given you, when you go to the bottom part of it, it is stated there that you should write your name, you should put your signature, and then the date. This is something that has also failed people, because if you write a care plan and you don't put your name, the date, and then the time, then it means that that particular care plan has no author. They cannot identify the person that wrote the care plan. So you have to make sure that you put your name, the date, and then the sign, and I also put that on the screen for you to see exactly where it is, so that you'll be able to do that. I always advise that should be one of the very first things that you do even before you start the whole care plan. Just go down to the bottom part of the sheet, put your name, put your initial, and put your signature. And even if you are beaten by time, you know that at least you have put these very important things that you're supposed to put on the answer sheet. It is there. So basically that will be it for the planning station. So these are some of the things that people fail to do, or they did not do, or they were supposed to do and they did not do it, and as a result they failed their planning station. So take note of it, and then when you are to take your exams, you try as much as possible to avoid some of these mistakes. Now let's look at the implementation station. With the implementation station, I'm going to divide it into procedural and then documentation. There were some procedural or some things within the implementation that once the candidate started doing it, they were supposed to do it, they did not do it, and as a result they failed. And then when we come to the documentation aspect, so there were also some things that they were supposed to do or they did and then they failed. So we'll look at the procedural first. The procedural has got the first one is not re-identifying the patient. So you know that when you start your implementation and then you walk in, you first introduce yourself, do the initial checks and all of that. Then you now go and prepare your medications, and then you come back to administer it. When you come back, for the first time that you do your initial checks, you introduce yourself, you have to identify the patient. You've identified the patient, all right. But when you leave the patient's bedside and then you go to prepare the medications and you come back, you have to re-identify the patient again to make sure that you are still with the right patient. And this is something that a lot of people did not do, and of course they failed. So please make sure that you re-identify your patient when you come back. Then the second thing is not checking for allergies. This is very, very important as far as medication is concerned, because you have to ask the patient whether the patient is allergic to anything, and then you take note of it, just in case the medications that you are going to be administering has anything that the patient is allergic to. You'll be able to avoid that, and that can be very, very helpful. So make sure that you check for allergies. A lot of people did not do that, and of course they also failed. Now the next thing is giving the wrong medication, and this can come into two ways. Either you are giving the medication that is not due your time, so the scenario will always be very specific, the time with which you are administering that medication. So they will tell you give 12 o'clock medication, 1 o'clock, 9 o'clock, 10 o'clock. So some people have given medications that were not due their time, and as a result they failed that, and giving another medication. So either they give medications that are not due their time, or they have identified a certain medication. They were supposed to give paracetamol and then they ended up giving brufen. So that is also another thing that people do, thinking that they were giving the paracetamol. So giving the wrong medication. These are the two ways in which it can happen. So you have to take note of it. Identify the medication that is due your time. Make sure that you can actually give that particular medication. When I say make sure you can actually give it, everything on that prescription to make that prescription valid should be there to make it valid. If it is due your time and the prescription is not valid, then you cannot also give it. So you have to make sure that you are able to do that. Then PRN. Then PRN too can come into two ways. Some people are not given the PRN, or they are given a PRN which they are not supposed to give. That is why at the initial part, when you enter into the scene, you have to check for pain, you have to check for allergies, you have to check for anxieties and all that, so that you are able to know whether you can actually give a specific PRN or not. If, for example, pain and there's paracetamol, you can give it so far as the patient has verbalized to you that he or she is experiencing pain. If the patient is also anxious and there's a medication, a benzodiazepam, like maybe diazepam itself, to be given, then you can also give that. But people do not do that, and then at the end they end up not giving a PRN which they were supposed to give. Sometimes the anxiety part of it might skip you, but then you are with this patient and continuously the patient keeps on telling you that I'm very anxious today, I don't know, but I'm a bit prickly, I don't feel very comfortable. When the patient starts to verbalize these things, you should know that the patient is experiencing some kind of anxiety. So you would have to probe further and then make sure that if there are any medications that are being prescribed for anxieties or agitations, you should be able to give this particular medication, as well as if the patient is also experiencing any pain and then there's a PRN for pain, you can also give that particular medication in that respect. Now let's go to the documentation bit of it. The documentation bit has got to do with the very first thing that we'll look at is you give a medication and you do not sign. So not signing, dating, and then you put in the time. So if you give a medication, as you can see on the screen, that particular portion that you are supposed to append your signature and then the dates, you make sure that you put that there. So if you give paracetamol, make sure that you go to the paracetamol box where you are supposed to put in the today bit of it, where you're supposed to put in your signature, and then you make sure that you put your signature, your date, and then your time. So yes, that's the very first. And then the second thing is signing at the wrong place. This is something that has failed a lot of people. I know that getting to the very bottom, it's just 15 minutes for this particular station. Getting to the very bottom part of it, usually either you spend so much time, so you are in a rush to sign. And then when you are in a rush to sign, sometimes you might sign at the wrong place. So you have to make sure that you always sign at the right place. If not, of course, they are also going to fail you for that. And then note coding. So if there's a certain medication that you did not give, but it was due your time and for one or two reasons you could not give it, then you would have to code it. So you have to make sure that you code this particular medication. And of course, the last page as you are seeing on your screen, any medication at all that you code, you have to make sure that you recopy that particular medication that you coded into that particular boxes. Is very, very important. If you coded on the main prescription and then you do not recopy them back into this particular boxes or this particular part of the prescription sheet, you will also be failed for it. And yes, so basically this is it. It's very, very painful when you've been able to go through the implementation process. You've given the right medication, you did everything that you were supposed to do, and now when it comes to the documentation bit, you missed something. You're not able to sign it very well, or even sign at the wrong place. It's very, very, very painful. So that is why you have to make sure that you are a bit fast. In as much as you are being fast with the procedure, you have to also make sure you do the right thing, so that there's always enough time for you to be able to sign, and then you even go through them to make sure that you are able to, sign at the right places. Before I even forget, on the page 2 bit of the prescription sheet, there's also a place where you have to put your name, your initial, and then the base. That's where you are. That particular bit, the very first sheet, that particular bit, a lot of people also miss it. A lot of people. The one you are just seeing on your screen right now. This one, when you start to read your prescription with the patient, when you get there, you can sign, you can write your name and put your initial right away. Make sure you do it before you even continue reading. It's very, very important. If not, when a lot of pressure build up at the last bit, all you are thinking about is signing for your medication, and you even forget that at the very first page you are supposed to have signed your name or write your name and then your initial in that very bit. And then you fail to do that, and of course they wouldn't hesitate to fail you at all for failing to do that. Yes, that is all for the implementation station. Let's go to the last one, which is the evaluation, and we'll look at some of the mistakes. This is not much. A lot of people do pass this particular station, but there are some one or two things that some people have not done or they do not do that have also failed them in the evaluation station. That is not giving detailed handover under the assessment bit of the SBAR. We all know that the situation, background, assessment, and recommendation, that is the SBAR that you follow to hand over your patient. In the assessment bit, there's kind of a lot of things that you have to talk about. You have to start right from the time when the main assessment of the patient is done to the bit or to the part where they were able to identify their problems, their risks, what was done about it in terms of nursing responsibilities, in terms of medical responsibilities, and even what were the areas of concern. It's kind of a bit broad under the assessment, and it has to be very, very detailed. But some people, when they get to the assessment bit, they kind of give a shoddy handover. They do not give a detailed handover right from the assessment to the interventions that have been given to this particular patient, and at the end the report will come and they will tell you that you did not give a detailed handover. And then one thing that I've also failed people is failing to hand over relevant information. Usually in the scenario, sometimes they can state categorically that they have prescribed a certain medication, they have taken out a certain medication, they have reduced a certain medication from a certain dose to a certain dose, they have increased the dose. This is a very important information when it finds itself in the scenario, and this is something that you're supposed to hand over. But people kind of read the scenario, they did not take cognizance of that particular part of the scenario, and then they just go ahead and do their handover without handing over that particular important information. If you do that, then they are also going to fail you, and then they will tell you that you did not hand over a very relevant information that was you did not hand over a very relevant information that was put in the scenario. So this is something that you also have to take note of. So these are the things that people fail to do in the evaluation station that also failed them in 2024. So yes, this is the mistakes that you should try and avoid in your APIE station as far as these particular 4 stations are concerned. And these are the mistakes that people did make in 2024, or these are the things they failed to do in 2024 that failed them. Take note of this so that you avoid doing these mistakes, or you do these things if you are now about to take your mental health nursing OSCE. My name is Enos, and this is Work and Wonder. Please, this is a new year. Make sure you share the videos, make sure you subscribe to the videos, and we kind of try and build a much more big community here on YouTube. This is the only channel that talks about the nursing, the mental health nursing OSCE. So let's try as much as possible to share it to people that are preparing for their exams, and I promise the videos that I have about 50 plus videos here, which will be very, very, very helpful for them. Under the description, you can also find a link to my APIE booklet. I'm almost done with my skills station booklet, which I also upload on that particular website, and then I'll always put a link in the description. In the link, you can also find a link to the WhatsApp group. You can join. We share ideas, we share documentations, everything that will help you to pass your mental health nursing OSCE. You can find it in that particular group. This has been the video for today. My name is Enos, and this is Work and Wonder. Until I see you again in my next video, it is a bye for now.